Hi everyone, our subject today is gynecomastia in pediatrics. Basics. Gynecomastia is enlargement of the male breast tissue owing to a decrease in the ratio of androgen to estrogen. Testosterone weakly inhibits and estrogen strongly stimulate breast tissue development. In males, estrogen is usually proceeds by the aromatization of androgens in peripheral tissue. Macrogynecomastia is when the breast tissue is greater than 4 cm in diameter. It is similar to middle and late stage of female breast development and is less likely to resolve spontaneously. Asymmetry of breast is common. However, any hardness of breast tissue or asymmetry placement of the nipple require evaluation. Lipomastia, the fatty tissue in the overweight boys, may cause pseudogynecomastia. Two age distribution peaks, neonate and pubertal. Neonatal gynecomastia occur in 60 to 90% of all newborns. Peak incidence for pubertal gynecomastia in males is 14 years of age, range 10 to 16 years. Onset usually at 5 to 10 mil testicular size and pubic hair tenor stage 3 or 4. 40% of pubertal boys develop transient gynecomastia, measuring more than 0.5 cm. History. Family history. Half of adolescents with gynecomastia have positive family history. Time of onset relative to puberty. Onset usually at testicular size 5 to 10 mm and tenor stage 3 to 4 pubic hair. Prepubertal more concerning than pubertal. Unilateral more concerning than bilateral. Rate of progression, rapid enlarging, painful gynecomastia with acute onset is of more concern than long-standing enlargement. Drug exposure including alcohol, marijuana, heroin, along with the exposure to exogenous estrogen and commercial products containing estrogens, lavender, tea tree oil, phthalines, ginseng, and others. Symptoms suggestive of hyperthyroidism, symptoms suggestive of liver disease such as cirrhosis, symptoms suggestive of renal failure, symptoms suggestive of neoplastic disease, symptoms suggestive of hypogonadism such as decreased libido, erectile dysfunction, or infertility may indicate an abnormal estrogen to androgen ratio. Physical examination. Assessment of malnourishment may result in hepatic dysfunction causing higher estrogen to androgen ratio. Perform a complete breast exam with the patient supine, grasp breast between thumb and forefinger and move digits toward the nipple. Look for firm, rubbery, mobile, discoid mound of glandular tissue arising concentrically below the nipple and areola. Measure diameter of the disc. Asymmetry and tenderness are common. Check for galactorrhea, which is a sign of drug ingestion or hyperprolactinemia. Masses not concentric around the areola that are hard, firm, fixed, that are unilateral or have any skin dimpling, nipple retraction, nipple bleeding, or discharge are concerning for carcinoma. This is very rare in male adolescent. Check for pseudogynecomastia, fatty enlargement. If present, no glandular disc will be palpable under areola. If disc diameter more than 5 cm, regression is very unlikely. Thyroid exam, goiter may indicate hypothyroidism. Testicular exam, consider testicular tumor with masses or significant asymmetry of testis. Consider gonadal failure for small firm testis. Gynecomastia more likely to be pathologic if testis less than 5 mm in this case not defined as pubertal gynecomastia. How to approach to patient with gynecomastia after performing history and physical examination? Is there medication used to know cause of gynecomastia? If it is yes, this is reactional drugs, alcohol, medication like heroin, methadone, alcohol, marijuana, amphetamines, hormones, antibiotic, antifungal, ketoconazole, anti-TB drugs, metronidazole, antiretroviral, cimetidine, ranitidine, omeprazole, furosemide, spironolactone, ACE inhibitor, calcium channel blockers, tricyclic antidepressant, phenothiazine, risperidone, diazepam, clonidine, and cytotoxic drugs. If there is no drug use, is there a normal pubertal onset, stage 2 to 4 puberty, age more than 10 years, breast tissue centered below nipple? If it is yes, this is physiologic gynecomastia or pseudogynecomastia. If it is no, is there a clinical clues suggestive of diagnosis, family history of permanent gynecomastia, abnormal asymmetry, breast tissue or nipple, history of a chronic illness? If it is yes, this is familial gynecomastia, local tumor or metastasis, or chronic illness. If it is no, there is no family history. Patient need DHEAS, FSH, LH, testosterone, estradiol, beta-HCG, free T4, TSH, prolactin with or without karyotype. According to the result, if there is an increase in DHEAS, beta-HCG, estradiol, patient need imaging study because this is tumor either in CNS, testes, adrenal, or liver tumor. If there is an increase in FSH-LH and decrease in testosterone, differential diagnosis, hypogonadism, Klinefelter syndrome, androgen insensitivity, enzyme defects, testicular injury, and gonadal dysgenesis. If there is increase in FSH-LH, decrease in estradiol, differential diagnosis, aromatase X's, aromatase secreting tumor, and familial estrogen secreting tumor. If there is increase in free T4, decrease in TSH, this is hyperthyroidism. If there is increase in prolactin, patient needs imaging study, this is prolactinoma or hyperprolactinemia, drugs or tumor. If it is a normal lab result, this is idiopathic gynecomastia. Alert! Do not mistake pseudogynecomastia, fatty enlargement of the breast, for true gynecomastia. Do not overlook drug-related causes. Drug-related gynecomastia is usually reversible if diagnosed during the year of onset. Top tips. Enlargement of the breast occurs in most male and female neonates as a result of stimulation by maternal hormones. Spontaneous regression is the rule. Their families need to be reassured. During puberty, up to 2/3 of boys develop gynecomastia that may be unilateral and tender. It is usually benign at age 10 to 12 years and peaks at 13 to 14 years, and regression is usual within 18 months. In gynecomastia, a firm or rubbery mass of the tissue can be felt extending symmetrically from the nipple. In obese boy, the breasts are enlarged due to fat tissue accumulation, pseudogynecomastia, without the characteristic rubbery consistency. Because of the increasing incidence of obesity, pseudogynecomastia is increasing. When mean hormonal concentration of follicular stimulating hormone FSH and LH, prolactin, testosterone, and estradiol in boys with gynecomastia are the same as in boys without it. Drugs inducing gynecomastia, they should be discontinued whenever possible. In a month after discontinuation, gynecomastia should have regressed. Surgical removal of the enlarged breast is rarely indicated except for marked enlargement that has caused emotional stress to the child. Red flag. In neonatal gynecomastia, discharge from the nipple colostrums should not be squeezed or pressed to avoid infection. Although it usually regresses within 2 to 3 weeks of age, in some cases enlargement continue up to 6 months of age. In contrast to the common occurrence of pubertal gynecomastia, prepubertal gynecomastia is rare but often unrecognized. Although the majority of them are idiopathic, it could be a sign of serious underlying disorders. Full evaluation is required. In any child with gynecomastia, efforts should be made to exclude exposure to estrogens, accidental or therapeutic. Increased pigmentation of the nipple and areola is an important clue. Gynecomastia associated with the neurological manifestations such as headaches and or visual disturbance could be caused by pituitary tumors. A cranial MRI is urgently required. In a child with gynecomastia, testes should be examined to exclude tumor or testicular failure. Any gynecomastia with galactorrhea, spontaneous flow of milk, may suggest the presence of prolactinoma as an underlying pathology. An urgent serum prolactin and cranial MRI are required. Gynecomastia can later become fibrotic, firm, sometimes hard, and has to be differentiated from breast cancer, which is rare and accounts for less than 1% of cancer in men. Red flags include unilateral mass that is hard, fixed, peripheral to the nipples or associated with nipple discharge, skin changes or lymphadenopathy. Klinefelter syndrome is common, 1 in 500 to 1,000 of newborn males, making it the most common chromosomal aberration and is associated with the gynecomastia in 80% of cases. The risk of breast cancer is 16 times higher than in other men. Monitor with the gynecomastia is important. Frequently asked question: when should a neonate with gynecomastia be referred to specialist? Answer: for male neonate, if galactorrhea persists at 3 months of age or gynecomastia not resolved by 1 year of age. Question: when should a non-neonatal but prepubertal male with gynecomastia be referred to a specialist? Answer: gynecomastia is in a prepubertal boy is rare and concerning. Urgent referral should be made to a pediatric endocrinologist. Question: when should a pubertal adolescent with gynecomastia be referred to a specialist? Answer: if gynecomastia is unilateral, if size more than 5 cm, if size is less than 5 cm but with the visible enlargement ongoing within 1 year of onset of problem, if started before the onset of puberty, if nipple bleeding, discharge or retraction, also if testes are less than 5 cm or testicular mass present, if abnormal hormonal workup or imaging study. Question: how can gynecomastia be distinguished from breast cancer? Answer: breast cancer usually presents as a unilateral, eccentric, hard or firm mass fixed to underlying tissue. Location usually outside the nipple areola complex. Associated finding can include dimpling of the skin, retraction of the nipple, nipple discharge, and or axillary lymphadenopathy. Breast cancer in pediatric population is extremely rare. Of all breast cancer occur in patients less than 20 years of age. Benign tumor such as fibroadenoma much more common than malignant tumor. If differentiation between gynecomastia and breast carcinoma cannot be made by physical exam alone, patients should undergo diagnostic mammography. Physiologic pubertal gynecomastia is common in adolescents. It occurs in up to 60% of boys aged 10 to 16 years and usually resolves spontaneously, 75% within 2 years. The breast tissue is less than 4 cm in diameter and resembles breast budding in female. Sign of pubertal development usually preceded gynecomastia by at least 6 months. Puberty is between Turner stage 2 and 4. Obesity is commonly associated with gynecomastia and is usually due to increased aromatization of androgen to estrogen by adipose tissue. Gynecomastia may also persist longer in obese boys. Lipomastia may also cause prominence of breast tissue known as pseudogynecomastia and is usually seen in obese boys. Familial gynecomastia may be X-linked or autosomal dominant. It may be due to increased aromatase activity. Unilateral enlargement, especially with the asymmetry and hard breast tissue, suggests local tumor. These are rare in adolescents. They may be caused by neurofibroma, dermoid cyst, lipoma, lymphoangioma, metastatic neuroblastoma, leukemia, lymphoma, or rhabdomyosarcoma. Gynecomastia may be seen in some chronic disease such as cystic fibrosis, ulcerative colitis, cirrhosis, malnutrition, followed by refeeding and acquired immune deficiency syndrome. It may be related to hepatic dysfunction. Uremia due to renal failure may cause testicular damage and decreased testosterone. If there is no evident etiology for the gynecomastia or there is evidence of hypogonadism, precocious puberty, or macrogynecomastia, obtain LH, FSH, estradiol, testosterone, dehias dihydroepiandrosterone sulfate, free T4, TSH, and HCG level. If testes are smaller than 3 cm in diameter or 8 mm in volume, or there is a history of ambiguous genitalia, a karyotype should also be obtained. If DHEAS is increased, imaging for adrenal tumor is needed. Increased estradiol level may require ultrasound of the liver, adrenal, and testes for hormone-producing tumors. Adrenal tumor usually cause feminization by conversion of androstenedione to estradiol. MRI imaging of the brain, chest, abdomen, and testes should be considered for evaluation for beta HCG secreting tumor, which may also cause precocious puberty. Other hormone-producing tumor include LH secreting pituitary tumor and prolactinoma, which cause galactoria but usually not gynecomastia. If galactoria is present, obtain a prolactin level. Karyotype may also be considered if there is a history of ambiguous genitalia at birth or if there is evidence of hypergonadotrophic hypogonadism, testicular size 8 mm, increased FSH, increased LH. In hypogonadism, gynecomastia developed during adrenarche owing to aromatization of adrenal androgen to estrogen. Klinefelter syndrome 47XXY usually present as delayed puberty, gynecomastia, small testes. Patients with Klinefelter syndrome have decreased testosterone level. In androgen insensitivity XY, there is end organ resistant to testosterone. In both conditions, Leydig cell action is retained and there is secretion of estradiol in response to the increased LH. testicular damage due to orchitis, injury, chemotherapy, or radiation, and congenital anorchia due to fetal testicular regression may occur and persist as gynecomastia at puberty. CNS injury, paraplegia may be associated with decreased testicular function leading to gynecomastia. Enzyme defect of 17-alpha hydroxylase, 17-20 dismolase, and 17-ketosteroid reductase result in decreased synthesis of testosterone. Patients with these defects may also present with the ambiguous genitalia at birth. Gynecomastia may also be seen in gonadal dysgenesis. Adrenal, testicular, and hepatocellular tumor may produce aromatase causing increased estradiol. Familial gynecomastia is an autosomal dominant condition and may be due to increased aromatase activity. Estrogen-secreting tumor are a rare cause of gynecomastia. 6-cord tumor with the annular tubes may occur in patients with the Peutz-Jeghers syndrome. They are multifocal and may secrete estradiol. Gynecomastia is seen in a third of patients with the thyrotoxicosis. It is primarily due to increased androstenedione, which is aromatized to estradiol. Hyperthyroidism also alters the androgen to estrogen ratio by increasing bounding androgen and decreasing free testosterone. Thank you for your listening.